So good morning or good afternoon, depending on what time I guess you're listening to this webinar. My name is Nimi Naran, and I'm an audiologist by profession, but I have a really strong background in psychology too. So firstly, I wanted to say thank you to Rural Health West for hosting this virtual conference and also reaching out to me today and asking me to present. I really value the opportunity. So today I'm going to be talking to you about delivering interventional and preventative hearing care and how you as a healthcare professional can partner with your local hearing care professional and help your patients to better hearing essentially. So just a small disclaimer before I start the presentation. I am employed by Audica, who is a hearing company across Australia and New Zealand. We've got around 400 sites across Australia, and I've been working for Audica for the last 9 years. You might be a little bit more familiar with our legacy brands of Hearing Life, Audio Clinic, Western Hearing Services, and Adelaide Digital Hearing Solutions. Last year, we made the decision to amalgamate our brands all under one banner called Audica. And for Audica, I am the head of medical services and clinical projects across Australia as well as New Zealand. So the primary objective of this particular presentation is to shed light on the emerging role that audiology plays in long-term care of patients, particularly your elderly patients and those who have multiple sort of chronic conditions. I want you to understand the prevalence of hearing loss and actually how common hearing loss is here within Australia, but also around the world. Over the last couple of years, and I guess over the last decade really, there's been a lot of research into the links between hearing loss and other sort of diseases, comorbidities, chronic conditions. And I really want you or sort of educate you in understanding those links and associations. And then lastly, I want to help you understand why prioritizing hearing in your consultations will be beneficial to patients, of course, but will also be beneficial to you in treating other healthcare conditions. So let's get started. Hearing loss is something that's highly prevalent among older adults and is often associated with a decline in things like cognitive function, physical function, as well as mental health. But despite these strong associations, hearing loss in the older population often goes untreated and generally receives very little clinical emphasis in primary care practices. And this has been shown in sort of several research studies here in Australia, but also around the world. Now, this is not to say as sort of general practitioners or GPs and nurses are not sort of helping patients that have hearing loss, because these studies are showing that when a patient is discussing hearing loss with a healthcare professional, the appropriate referral is taking place, which is fantastic. The problem lies is that patients don't talk about their hearing. Hearing loss is something that's considered a hidden disease and really gradually progresses over time. So one, people don't know they have a hearing loss often in the early stages. Two, there's a stigma against hearing loss. So people are not actually discussing it with healthcare professionals for that referral to go through. So we really need to shift our mindset. So at the moment, we've got a reactive model of care towards hearing loss. But we really need to shift that into an interventional model of care or a preventative model of care so that we can identify more patients with hearing loss and help them. Now, when we think about other diseases that you'll be treating and monitoring on a daily basis, many of these take a preventative model of care. So it's something that you're used to. You ensure that diseases are monitored for people who are at risk or people who are at a certain age. Hearing loss should be no different. We should be providing the same level of care for this particular chronic condition. And as a healthcare professional, you're really on the front line and are best suited to introduce hearing awareness and educate your patients on hearing. Now, in order to understand who is at risk, we really need to understand prevalence. So let's start with taking a bird's eye view of hearing loss across the world. The World Health Organization has reported that there are 466 million people in the world with disabling hearing loss. And this particular graphic that you see on your screen at the moment is from the World Health Organization. A strong majority of these are adults, making up around 93% of the group. Global onset hearing loss is the second leading cause of years living with disability behind depression. That is significant, and that is so important when we think about hearing loss. Now, with hearing loss, unless action is taken, it's likely that these numbers are going to increase and they're going to grow, with projections showing that we could almost double to 900 million by 2050. If we now sort of narrow our focal point and focus on Australia, in Australia, currently 1 in 7 Australians suffer with hearing loss, making up around 3.6 million people. In Australia, around 14.5% of our population. Hearing loss is currently a significant health concern as well as an economic concern for our government, and this is only growing with our aging population. Hearing loss is predicted to increase to around 8 million people by 2060, meaning that 1 in 5 Australians will suffer with some level of hearing loss. Now, how does this actually compare to other sort of health concerns that you're seeing in your office and you're treating for your elderly patients? So if we look at arthritis first, very, very similar statistics to hearing loss. 1 in 7 people suffer with arthritis, making up around 14% of the population. If we look at diabetes, a little less common, so 1 in 20 Australians suffer with diabetes, around 6% of the population. And then if we look at hypertension, 1 in 3 Australians suffer with hypertension, making up around 34% of the population, so just a higher prevalence there. Just take a quick water break. So age-related hearing loss is something that's really considered as a triple threat to patients. And there's sort of 3 main reasons for that. Firstly, clinical significant hearing impairment is a disability in its own right that requires treatment for the patient. Secondly, hearing loss interferes with the patient's ability to be treated for other medical conditions, because it hinders an individual's ability to engage with you and understand your treatment, your advice, and your directives. So this is really, really important, an important point in my eyes. When we look at research, patients are only retaining around 20% of what we're saying in our consultations. When we add hearing loss into the mix, patients are now mishearing information as well as not hearing some information. So when you're talking to your patients about a treatment plan or advice or giving them a directive or something related to their health, if they're missing out on key information here, that's really important for them going home and following your directives as well as following the treatment plan that you set out, because they're not actually hearing it very well. And then lastly, emerging research suggesting that hearing loss may actually accelerate some disabilities, as well as adversely affect some chronic conditions. So the broader implications of hearing loss are increasingly surfacing in epidemiology studies. Hearing loss now is independently associated with various things like mortality, poorer cognitive function, incidence of dementia, depression, physical function, and the list goes on. Now that this research is there and it's showing these associations between hearing loss and other conditions, we as healthcare professionals can no longer treat hearing loss in, I guess, a vacuum or a silo. We really need to start thinking a bit broader about hearing loss and how hearing loss fits into the patient's general health. Now, research regarding these associations and these links have really emerged over the last 10 years, and there's been a lot of focus in research into this area, showing management of hearing loss cannot again be treated as that isolated sensory disorder. We have to consider physiological as well as the psychological effects on a patient. So if we sort of look at the physiological considerations first, the presence of hearing loss is associated with things like cognitive decline, cognitive impairment, dementia, brain atrophy, as well as reduced brain volume. We know untreated hearing loss results in sort of a patient being inactive, less likely to participate in conversations, as well as social gatherings. This then has psychological consequences of increased worry, stress, loneliness, depression, anxiety, as well as a reduction in self-esteem, which then makes these patients a lot less independent or confident to be independent. Hearing loss is definitely something that is not going away. We really need to think about the broader implications of hearing loss and how we treat this in our patients in order to help them age well. Now, over the next couple of slides, I'm going to be talking to you about hearing loss and other chronic conditions or diseases that you see in your office and how hearing loss actually is associated with these. Now, as I've mentioned on the previous slides, there are many associations with hearing loss in terms of medical conditions, but today I'm only going to be covering 4 of those. But there's a lot of research out there if you want to do additional reading, or if you want to know more about the topic, you can definitely reach out to myself. I'm happy to take the conversation further. But firstly, let's look at falls. So falls is a leading cause of fatal as well as non-fatal injuries in older adults, leading to significant health concerns. Falls can often sort of lead to a fatal outcome within the first 12 months of the injury, particularly with older Australians. In 2012, Lin and Forsey explained the association between falls and hearing loss. They looked at this association among around 2,000 people that were aged between 40 and 69. They found a significant association. Patients with mild hearing loss were 3 times more likely to have a history of falls than those with no hearing loss. As hearing deteriorated, that risk of falling increased significantly. So every 10 decibels, every additional 10 decibels of hearing loss increased the risk of falling by an additional 40%. Now, this was a great study because it monitored this association, but it also adjusted for many confounding variables like demographics, cardiovascular disease, vestibular, balance dysfunction, but none of these substantially decreased or affected the magnitude and the significance of the association between falls and hearing loss. So how do researchers actually explain this association between hearing loss and falls? There's a number of mechanisms that we must consider and that we see in research. The simplest direct mechanism is that people with hearing impairment fail to detect environmental hazards that are outside their line of sight. So basically, their awareness of their environment is reduced. So for example, if we think about somebody who's hearing impaired, if depending on their hearing loss, of course, if a broom falls, they may not hear this. If they've got their grandchildren over and a wheeled toy sort of wheels in front of them, they may not hear this. There may be a spill in the kitchen and a loved one calls out, "Oh, don't come in the kitchen, the floor is wet." Because they're not hearing these items or these things happening in their environment, their auditory awareness is reduced and therefore increasing their risk of falling. Secondly, it's been suggested that people with hearing impairment require more attention to detect and process auditory cues, meaning that there's a larger cognitive load to detect and understand speech, but also detect and understand what's happening in their environment. The increased sort of cognitive load then results in fewer cognitive resources for things like memory, maintaining balance, gait. So basically, the brain is overwhelmed with the demand on its limited resources. The third mechanism is that impaired hearing is also a marker for vestibular impairment. So we know the auditory system and the vestibular system are connected. The vestibular system detects head movement, acceleration, and is really important for head and neck stability as well as balance control. So if we generalize, if there is a dysfunction or something affecting the ear, we could see a degradation in both the hearing organ as well as the balance organ. And then finally, it's been reported that poor hearing can lead to social isolation as people are less active. They don't want to engage with others because of their hearing issues. They don't want to engage in social encounters because they can't hear. So this subsequently then reduces quality of life and well-being and aging well. So for me, I guess the next logical question to ask is, can hearing intervention actually help? And the short answer is yes. We know hearing intervention can improve 3 out of the 4 mechanisms of why hearing loss increases the risk of falls. And this is improved environmental awareness, reduced cognitive load, and thirdly, it allows patients to connect and communicate with others, therefore reducing that social isolation. There's a large amount of research in this area covering these 3 mechanisms. Regarding the last mechanism of poor balance, there's not as much research in this area, but there was a good study done by the Washington University School of Medicine that found hearing devices did more than just increase alertness in the environment. When participants in the study were instructed to sort of do balance tests, they performed a lot better when they were wearing a hearing device compared to when they weren't wearing a hearing device. They suggested that the hearing device allowed the participant to use sound information as auditory reference points in maintaining balance, similar to how we use visual cues. So as a healthcare professional, how can you help your patients who are, 1, at risk of falls, or your patients who have had a number of falls? So early intervention and preventative audiology is really important in this area. We need to be monitoring hearing of patients as they are getting older. In my clinical opinion, everybody over the age of 55 should be getting regular hearing assessments or screenings. After the initial diagnosis, they then need to have regular checkups. Now, this usually will occur annually or will occur once every 2 years. And this is very dependent on the health of the patient and whether a hearing loss was present in the first place. Now, this is what we're dealing with preventative model of care. But if your patients have had a number of falls already, it's really important to discuss hearing health with them, to refer them for a full diagnostic assessment, and encourage intervention if a hearing loss is present. Next, I want to discuss diabetes. Now, with diabetes, research is strongly and consistently suggesting that diabetics compared to the non-diabetic population are at higher risk of developing hearing loss. The hearing loss is more than twice as common in adults with diabetes compared to those who do not have the disease. So a certain degree of hearing loss is a normal part of aging, and it's going to happen to you and it's going to happen to me as we age. But it's often accelerated in patients who have diabetes, particularly if their blood glucose levels are not being controlled through things like medication, diet, or exercise. There's also further evidence to suggest that diabetes-related hearing loss is separate, completely separate from age-related hearing loss, with some studies showing that there's actually a stronger association with diabetes and hearing loss for those people who are under the age of 60. Other sort of interesting stats or statistics on hearing loss and diabetes is that people with diabetes are at a higher risk of progressive hearing loss. So I alluded to this on the previous slide. Therefore, their hearing is deteriorating faster than the general population. They're also at a higher risk of sudden sensorineural hearing loss compared to non-diabetics. So sudden sensorineural hearing loss, as the name suggests, is a sudden change in hearing, and the sensorineural component indicates that it is a permanent change also in hearing. There is evidence in that category, and I won't go into this too much, but there is evidence to show that if we do treat sudden sensorineural hearing loss within a sort of 24-hour to 72-hour window, depending on which study you read, with steroid treatment, that this can help to recover some of the hearing or all of the hearing, but this doesn't work in all patients, but it is very sensitive to that time window. Pre-diabetics have also been considered in the literature and research, and they're also at risk. Studies have shown a higher prevalence of hearing loss in pre-diabetics compared to those people in the population with normal blood glucose levels. The pathophysiological explanation of diabetes-related hearing loss remains really speculative at this stage. However, it has been suggested that the vascular and the neuronal damage that comes with high blood glucose levels may be the underlying mechanism. It's known that high blood glucose can damage little tiny blood vessels and nerves in various organs, such as the eyes and kidneys, and it's suggested that the same thing is happening in the hearing organ. Further investigation, of course, is needed into this area, and it definitely would be welcomed by the audiology community. So again, how do we care for our patients with diabetes? As an invisible condition, hearing loss can be undetected for a significant number of years. The average data at the moment is showing from onset to hearing loss to when a patient actually has their first screening is at 7 years, which is a significant period of time. Patients with diabetes should definitely be closely monitored by general practitioners and nurses to manage the condition, of course, but also for referral for audiometric monitoring. So I always would recommend that anybody that's newly diagnosed should have their hearing assessed, so full diagnostic hearing assessment, which will then provide a baseline for their hearing, and then careful monitoring on a yearly basis would then occur after that. And this is something sort of once the initial diagnostic assessment takes place, your audiologist or your audiometrist will put these screening measures in place to ensure that they're monitoring these patients because they have diabetes. Thirdly, of course, work closely with yourselves to control blood glucose and to prevent any complications. And then lastly, minimizing any risks. The next topic is dementia. So people with hearing loss are significantly at a higher risk of developing dementia than those with normal hearing. Patients with a mild hearing loss are 2 times more likely to develop dementia. 2 times more likely to develop dementia than those with no hearing loss at all. And then the risk also increases with severity of hearing loss. So people who have a moderate hearing loss are 3 times as likely to develop dementia. And then people with a severe hearing loss are 5 times more likely to develop dementia. Hearing is an integral part of cognitive change and dementia. Now, the relationship between hearing loss and dementia has probably received the most attention in press out of all the comorbidities or the associations I've talked to you about today, but also all the comorbidities that exist in research today. There's been a number of landmark studies in the area, but I think the commission from the Lancet Journal in 2017 on dementia prevention, intervention, and care really elevated interest in this area by healthcare professionals as well as the public. The commission also really elevated the importance of hearing to reduce the risk of dementia, and also just pointed out how important hearing is when we're talking about dementia. So research has identified a number of factors that may increase the risk of developing dementia, as well as the number of risks that may reduce the risk of developing dementia. They're classified into 2 categories, modifiable risk factors and non-modifiable risk factors. So 35% of risk factors were considered modifiable. So you and I, or everyone, has control over these. They can change these in their lives to reduce the risk of dementia. Of the 9 modifiable risk factors on the slides, you can see them today, the largest modifiable risk factor in midlife, and that's important, in midlife, was hearing loss, accounting for 9%. So this is not somebody treating their hearing loss later in life, in their 60s and 70s. This is somebody doing something about their hearing in midlife, can reduce the risk of dementia. Research also shows that The other sort of areas that reduces the risk, and you can see on the slide I've highlighted, things like hypertension, depression, physical inactivity, social isolation, and diabetes is related to a modifiable risk factor for dementia. But these are also associated with hearing loss. Something important to note is that hearing loss is not a symptom of dementia. However, treatment of hearing loss can reduce the risk of dementia. So what are you going to be, as healthcare professionals, doing to help your patients? Again, hearing checks annually, encouraging good hearing health, educating your patients on hearing health and how it, I guess, plays an importance in risk of dementia, and also minimizing any of the risk factors. The last sort of association that I'll be talking about is cardiovascular disease. So in 2010, researchers Hull and Kershaw, they published a review of more than 60 years of research, finding that impaired heart health had a negative impact, particularly in older adults, on hearing health. The link between cardiovascular disease and hearing loss has now been documented in over 200,000 patients. The evidence shows that the prevalence of cardiovascular risk factors, as well as cardiovascular disease, increases the odds of developing a hearing loss by 50% and contributes to a greater rate of hearing deterioration. Improved heart health also had a positive influence on hearing health. So what does the heart have to do with hearing? Simply put, it's all about blood flow. The inner ear is extremely sensitive to blood flow. Heart problems, of course, cause a buildup of plaque in the arteries, restricted blood flow, which then causes irreversible damage to the ear. In the ear, there are delicate nerves in the cochlea that play an important role in translating sound in the ear to an electrical impulse that then goes to the brain. Poor circulation can reduce the adequate levels of oxygen to the hearing organ, and then this causes irreversible damage to these nerves. Impaired cardiovascular health has negative impacts on both the peripheral as well as the central auditory system in older adults. The implications of that are twofold. The prevention of cardiovascular disease and its contributing factors has the potential to slow down age-related hearing loss, and improved access to hearing healthcare surveillance can also help reduce the overall health burden. So to tackle this problem, healthcare professionals can offer routine consultations to look to identify patients that are at risk. Again, early intervention and appropriate referral in this area is also really important, and then monitoring hearing and reducing any risk factors again. So for the next couple of slides, I'm going to be talking to you about screening and why it's so important. So for our pediatric population in Australia, we have a number of screening points to ensure that we detect and treat hearing loss early, as we know that early intervention with hearing is so important. So infants get screened 2 to 3 days after birth while they're still in hospital. There's various screening points during the health checks in early childhood, and then there's various screenings that occur for children who are school-aged. But we don't have the same measures in place for our adult population, despite knowing early intervention is so important. We should be working towards making hearing screening a standard part of care for our adult population, just as it is for our pediatric population. So screening always will be the first step to accessing care. Therefore, as a healthcare professional, you again are arguably the most important and the most influential in the patient's access to treatment and primary care. Many patients don't discuss hearing loss, as we talked about earlier. One, they may not be aware that they have a hearing loss because it's so gradually progressing. Two, the stigma against hearing loss makes people less likely to talk about it. All of this makes screening essential. If patients are not going to talk about it, we need to screen for it. In saying that, I know as healthcare professionals, GPs in particular, face a significant number of time demands, and they're seeing many patients in a small sort of time frame. Therefore, I wanted to share with you one sort of screening method that's simple, it's accurate, it's not expensive, it's reliable, and is not going to take up a lot of your clinical time. This particular screening method is called CALFRAST, and again, it's a great tool to use in your office. It's an acronym and of course stands for Calibrated Finger Rub Auditory Screening Test. And it can be part of a routine test procedure for your older adults. And it's very effective in identifying hearing loss, incomparable to other sort of screening methods that are out there, taking into account time. So again, the CALFRAST is an auditory screening test. So how do you actually perform this particular test? The sound that the patients are hearing is simply created by rubbing your fingers together, just as I'm doing right now. Patients should be sort of sitting on a comfortable seat or a bench or bed in a quiet room. So this can be in your office. The steps to performing this particular test is firstly, when your patient is comfortably seated, demonstrate the finger rub sound. So you're just rubbing your fingers together, telling the patient, this is the sound that you're listening out for. Explain the response or how the patient responds. So often when I'm doing this particular test, I will tell the patient, if you hear the sound, raise your hand. If you hear it on the right, raise your hand on the right. If you hear it on the left, raise your hand on the left. This then helps you gain localization information. You also want to encourage your patients to really listen for even the faintest sound. Once the patient understands the instructions, you want to ask them to close their eyes. You, as the tester, want to stand around 15 to 30 centimeters directly in front of the patient, so sort of nose to nose, around that 30 centimeter marker. And what you want to do is extend your arms out. So I'm just going to move back so you can see this, but you want to extend your arms out laterally like this. So essentially, your hands will be around 70 centimeters away from the patient. You then want to present what I call a CALFRAST strong. So rubbing your fingers quite briskly together on one side and then giving the patient some time to respond. After the patient has responded, you present again. Now, with this particular test, I always recommend presenting a couple of times on each side. So you may do 2 or 3 presentations on each side, vary the side that you're presenting it on, and also vary the time between presentations so the patient essentially can't guess. Next, you would do a CALFRAST faint. So with a CALFRAST strong, you're rubbing your fingers quite briskly together like this. With a CALFRAST faint, you're doing it a lot slower. And if you do that at home right now, you'll notice that the sound that the CALFRAST strong is louder, of course, whereas the CALFRAST faint, rubbing your fingers slowly, creates a much fainter sound. And then the procedure is exactly the same. The patient will tell you if they've heard it or not by raising their hand on their right or their left. So let's look at the results. So if the patient has accurately heard the CALFRAST strong and the CALFRAST faint on multiple presentations, they've passed the screening and it's highly likely that they have normal hearing. If the patient had some difficulty hearing the CALFRAST strong or the CALFRAST or I should say the CALFRAST faint, they should be referred for audiological testing because it is highly likely that they have some level of hearing loss. The last thing I would suggest that you look out for is a localization issue. So if you're presenting, let's say, the CALFRAST on the right-hand side and the patient lifts up their left hand, they're having localization issues in terms of telling where that sound is coming from. Now, this could be one of several things. It could be occluding wax in their ear. It could be otitis media and infection. So a simple otoscopy examination would reveal this, which is great. If both of those are clear, patient doesn't have occluding wax and doesn't have otitis media, then we really need to consider one, a unilateral hearing loss or a hearing loss where there is a difference between the ears. So if your patients are having localization issues, you should also definitely refer for full audiological testing. Now, if you're short on time and you can't even think about adding a screening like this into your appointment, that's okay. As a GP, we know you're busy. It's understandable. You're seeing a lot of patients in a day in a small time frame and discussing many health conditions. So if you're in this situation and you're thinking this right now, what I would suggest is that all patients over the age of 55 should be referred for routine hearing screening. So let your local provider, if it's Audica, do the screening for you instead of you doing the screening, and then we'll take it from there. Now, the first question, I'm always a person that likes to understand. So my first question is why 55? Prevalence of hearing loss increases as we get older. We know this, and it's depicted by the graph you see on the screen. So at the bottom there, you've got age, and then on the vertical axis, you've got rate or prevalence of hearing loss. So we can see in the 60 to 69 age group category and the 70 to 79, there's really a peak in that age-related hearing loss. And the data here is showing that 58% of people between the age of 60 to 69 have hearing loss, and 74% of people aged between 70 and 79 have hearing loss. So it's important to consider this peak age group, but early intervention preventive model of care, we also really need to consider the 50 and 59 age group, because this is where hearing loss is starting to increase, and you see that level increase in that graph. So that's why I've indicated 55. We need to be starting to educate patients at this age about good hearing health. We need to be monitoring their hearing and making it part of routine health checks that they have, in the same way they do for eyes, for example. Okay, so just a small conclusion. A couple of take-home messages. If you've sort of stuck with me throughout this presentation, thank you. A couple of things that I really want to hit home is firstly, collaboration. Reach out to your local clinicians, your local Audica clinic or any other hearing clinic in your local area. Talk to the audiologist, talk to the audiometrist, work collaboratively with them to improve patient care. In audiology, we are always happy to work with other healthcare professionals and sort of raise awareness around hearing. Next, look out for hearing loss. So for patients who are over 55, refer them or conduct a CALFRAST screening within your appointments routinely for older adults. Next, look out for the comorbidities. So we talked about hearing loss and its association with diabetes, cardiovascular disease, dementia, and falls. Look out for those in your practices moving forward and refer patients for the appropriate hearing checks. Aging well equals hearing well. Hearing intervention is a vital part of aging well and keeping your patients active and engaged in the community, with their family, with their friends, and even engaged within your offices. We know prevalence, hearing loss, is a lot more common than you think. And then lastly, hearing loss being that triple threat. So hearing loss in itself is a chronic condition that needs treatment. Hearing loss affects your treatment of other health conditions within your office, simply because patients are not hearing your treatment advice, your medication options, or just the general conversation that you're having with them. And then lastly, hearing loss affects other conditions, and it can also accelerate some other conditions. Hearing health should not be assessed or looked at in a vacuum or a silo anymore. There is simply too much evidence out there that hearing loss is associated with so many other health concerns, some of which we talked about today, some of which we didn't, but things like cognitive impairment, dementia, cardiovascular disease, falls, diabetes, depression, loneliness, social isolation, anxiety, mortality, and the list goes on. It's really time that we maximize this information in order to benefit our patients overall well-being and focus on a preventative or an early detection and evidence-based treatment. So thank you for your attention today. Hope you found this particular presentation interesting. If you do have any questions, my details are on the slide. Please feel free to reach out. I'm more than happy to have a conversation, send you journal articles if you want further reading, anything that I can help to educate you. So thank you.